Hey everybody, welcome to another episode of Under the Avocado Tree. Today we are joined by someone who I'm extremely excited about interviewing. Um, Her name is Dr. Brandy Drake. She is a board certified emergency medicine physician. She is now also working on her board certification for palliative care. She has trained at a very prestigious institution here in Colorado, Denver Health, graduated in 2013. So she's been a physician for 11 years and has been practicing within her specialty now for 7 years. How you doing, Dr. Drake?
I'm doing well. Thanks. It's good to talk to you as well.
Excellent. So I know that it's been a long day. You're coming home from work and you're
Yep.
taking time out of your busy schedule, which I'm sure is only getting busier as the cases of COVID-19 begin to increase. On a personal note, and really for all of our listeners, thank you so much for taking time out of your day and out of your family to connect with us and help us understand a little bit of what you're beginning to see now as a physician in the emergency room. So before we began talking, you were telling me about the role of an emergency room physician and kind of what that position looks like when somebody arrives in the emergency room. So can you help us understand initially what that role looks like for you on a day-to-day basis?
Yeah. So we're essentially your frontline providers in terms of stabilizing patients. Um, so patients come to us, either on their own or through the ambulance, and we're sort of your initial triage team, trying to figure out are you sick enough that you need to stay in the hospital? Do you need any emergent intervention in terms of your respiratory status or things like that? Try to identify what this is so we can figure out where you're headed. Um, Fortunately for us, so far most folks are able to go home, but then we have to try to figure out, really identify those folks that are sick enough to need to be in the hospital or in the ICU. So we're your sort of initial triage and stabilization team is our main job.
Excellent, excellent. And so, in regards to obviously this topic that everybody's talking about right now, which is the COVID-19 or coronavirus pandemic, talk us through a little bit about how that process works. What are you guys looking for? What are you trained to look for? And how do you begin to even make some of these decisions when somebody is presenting with a suspicion of the infection?
Um, yeah, I think, everything has changed for us with this pandemic in terms of how we normally take care of patients. We always pride ourselves on we are open for everyone at any time, at all time for any issue. And that has actually changed. Um, our hospital's done a really good job of we're trying to keep the emergency department really for the sickest of the sick. And so we are, first of all, triaging folks that are not emergently ill off to what we call our respiratory support center. It's literally a little tent, a makeshift tent, which a lot of hospitals are doing outside of the ER. So our first step is seeing, are you well enough to go there? And then if you're not, if you need to come to the ER, either for presumed coronavirus or something else, you know, are you well enough to go home, or do we need to keep you in the hospital? Um, our biggest struggle right now, as I mentioned to you before, is that we don't have good testing capabilities. So we assume every single person, we actually right now, even a patient comes in with a trauma, we assume everybody has coronavirus all the time right now,
Okay.
even if you're not showing symptoms, because we know a good chunk of patients are asymptomatic, at least in the beginning or potentially through their whole course. So we're treating every single person in our hospital that comes through my doors as a coronavirus patient. Um, and so we're protecting ourselves, at all times for that. Um, and then from there, if we're seeing sick patients or these folks again we're sending home a lot more folks than we used to. Um, Sending folks home with home oxygen, potentially that we would previously keep in the hospital. Um, we are predicting, following models from around the world. We have we're able to learn from the countries that have been through this. So we are predicting a big surge and trying to keep our hospital open and available for those really sick folks.
Hmm.
So sending home a lot more patients than I normally would.
Hmm.
Also sending home folks who maybe aren't here for coronavirus, but I don't want them to be in the hospital because they
Correct.
might get coronavirus in the hospital.
Okay.
We are essentially a warm zone, meaning that we viruses around us at all times in the hospital. Basically, it's impossible to keep it off all of our surfaces.
Yeah.
So it's a dangerous place for people to be.
So let's open that up a little bit because I'm assuming that this has drastically changed, procedures and when people are allowed into the hospital. I've heard two different theories. One of them that the virus can live, depending on the surface, up to 3 days. Some people say up to 7 days. So how are you guys kind of approaching this from a provider standpoint?
In terms of like protecting ourselves, or
Correct.
yeah.
Yes.
So yeah, you're right. I don't think we totally know, but it does live on surfaces for days, especially plastics, which is everywhere.
Mhm.
Um, and so we in our hospital, I have to say, like, I'm very proud of where I work in terms of their very proactive response to the virus. We have shut down all elective procedures, surgeries, everything, which is a big financial hit for them, but it's the right thing to do. Um, and so, I mean, we screen every single person that walks in the door. We have very limited access to the hospital. When you come in, you immediately change your clothes, put on new hospital clothes. Your hair is covered, my face is covered. We're constantly washing hands. Um, Minimal, we go to different locations to eat. Um, we are we have a warm hall in our ER right now. And I would say we have like a three-phase plan. Right now we're still in phase one, which is good. Which is like I have a warm hall of my ER and a cold hall where my non-coronavirus patients go. And right now that's actually a little hard because I have to constantly go into my warm zone and don my full PPE, uh, clean up, try to feel clean, and then go to the cold zone. Um, I will say we have every single patient wear a mask in the hospital for their protection and ours, because we have non-corona patients in the hospital for trauma, for lacerations, it's all that stuff. We want them to stay safe too. So they're all wearing masks, washing hands, etc. So yeah, I mean, we're being hyper vigilant. I tend to not be. I'm always of the camp of like, germs are good. We don't want to sanitize things too much, etc. And this is a different beast. So I never used to shower. We then change out of our clothes. I come home, I go right to the shower. I shower every day, which is very unusual for me. But we're taking extreme measures right now.
Wow, that's very it's intense. It almost feels heavy
Yeah,
because the degree of responsibility and not even responsibility of awareness and alertness seems like it has to be so
yeah,
heightened because of this additional
yeah,
factor that now plays into every single movement, every single step, every single procedure that's going on when you are working up a patient, it seems like.
yeah. And like today, I told you I had a really sick patient. It was just particularly, you're just particularly thoughtful, yeah, of everything you touch. Okay, I touched this thing. This thing is dirty. Now I have to take out this thing that has it. Oh shoot, I just touched my glasses. I wear glasses usually. I'm constantly like pushing them at my face. And I'm like, oh, my glasses are covered in virus. And so I'm washing my glasses. And it's just, I think it's funny because I often feel safer at work because I'm so careful. Um, and I haven't been nearly as safe at home. Um, and I probably need to extend that same level of safety at home as I'm using at work right now.
Wow. Wow. And help us understand a little bit when somebody shows up and they're either suspecting that they're carrying the virus or they're presenting symptoms. What are some of the things that you guys are looking for that kind of sounds that flag for you that tells you, hey, this is escalated, this is, at a bad place, we need to consider bringing this in, or, this is someone that perhaps can go home. What are some of the criteria that you guys are utilizing or are trained to use for those decisions?
I mean, I think our biggest one is their vital signs. Like we always say, vital signs are vital for a reason. Um, Oxygen level is a big one, their work of breathing. We do have some lab tests that we are following. Some of the studies are helpful in that regard, looking at some of the inflammatory markers. So we're using some lab values to help us. Um, we're doing checking LDH, ferritin, D-dimer, CRP on everybody. Because if those are all normal and the patient looks pretty good, that's I feel pretty confident that's the patient is going to be okay at home. And I would say okay at home for now.
Right.
We know it peaks at day 8 to 10, 8 to 12 maybe. So I always tell people, things look good right now. There's nothing different I would do for you in the hospital. So I don't want you to sit in the hospital in a bed and get sick here. So go home, stay home. And if things get worse, you have to come back because we know things can get worse as it progresses. Um, but yeah, it's a combination of their vital signs, their labs. Um, Chest X-ray is not super helpful. It's often normal, especially early. Um, CT is super helpful, but we also don't want to be irradiating everybody. That's a little bit of a gray zone for me right now. Is is when we need that. But CT findings are actually we've looked at our CT in our COVID just today. We looked at our COVID positive patients and their CTs, and CT is very very sensitive. Um, it's been shown too that even asymptomatic patients, you can see findings on their CT
Hmm.
uh, before they get symptoms. But again, we don't want to irradiate everybody. That's not the right way to practice medicine.
Of course.
Um, so that's still a gray zone for us. But
Yeah, yeah, that makes a lot of sense. And I've read too that, that the popcorn finding in the lungs, that
hmm
presentation seems to be present way before, a
hmm
lot of these patients escalate. And I'm sure that's a really tough decision to have to make. At what point is it justified to order a test that's exposing them to radiation?
hmm
To, would it be used as a confirmatory test? Would it be used to assess the degree of severity? What are some of the thoughts around that right now?
yeah, we're mostly using it right now on hospitalized patients to get a sense of where they're at with their illness and for prognostic purposes. Um, but yeah, it's not really. It's not been recommended except for patients that are really severely ill. It's a big, just logistical issue with us because if a patient goes to CT, it takes out that CT scanner for at least 30 minutes. So then, where I work, I've got two CTs, so I've got then one functioning CT for anything else that rolls in my door. So we have to think of those issues too. Do I want to take that scanner down for 30 minutes? um, and I'm exposing the hall. I'm exposing the CT techs. It's not something that is just like, oh, I'll order a CT. It's no big deal. It is kind of a big deal, but it is also super helpful. I will say a lot of times their CT looks a lot worse than they do, so it's a little tough there too. It's hard to discharge a patient whose CT looks terrible, but they look good. It's a little scary.
Yeah, and it'll be interesting, in the next thought that crosses my mind, it'll be interesting as cases begin to recover to assess, and I don't know if you've seen any studies on this yet, but assess if the changes that are seen on CT during the active infection actually resolve, or if there's, any type of
Mm,
long
hmm
lasting effect
Yeah,
in the respiratory tract after,
yeah.
scarring or whatever it might be. So it might be, interesting too from that point of view.
Yeah, I wouldn't be surprised if it leaves scarring, and especially patients that have diffuse disease. And that's the thing about this is it tends to affect both lung fields pretty diffusely, rather than like a bacterial pneumonia just kind of localizes to one side or the other, one lobe or the other. This is a diffuse process um, that But that is an interesting question.
And so let's talk a little bit about people with pre-existing illnesses. What are some of the main concerns for you when you're triaging and making some of these decisions? What are some of the chronic illnesses that really seem to elevate risk of morbidity or mortality for these patients?
I mean, the classic ones are patients that are immunosuppressed, either from some underlying illness or meds. Um, Patients on any of the medications for the biologics, so chemotherapy. Diabetics always are immunosuppressed, so that's a big one. And then there's an interesting thought of patients with hypertension, especially there's some question of patients on ACE inhibitors. This is another gray zone for us right now. The current guidelines say we should keep their ACE inhibitors on board, but the way the virus works, it like upregulates the ACE receptors in the lungs.
Hmm.
Um, and so there's some thought that that med is a potential risk factor. There's some early studies out of Italy with patients on ACE inhibitors that maybe they did worse. But again, that data is not robust enough to say, okay, you're on this, you should stop it, especially if it's controlling your blood pressure. Um, but that's kind of an interesting one. We don't tend to. I don't tend to, as an ER doc, stress hypertension too much. It's like me. Everyone's got high blood pressure. It's fine. I mean, we know it's that silent killer. It does have very significant long-term effects. Um, but it's one as an ER doc, I don't. And maybe because it's so prevalent, I'm so used to it, it doesn't strike me, but it tends to not bother me. And in this case, it's a little more, it does pique my interest a little bit when I see that. Age obviously is a factor, although we are certainly seeing illness and death in young people, um, meaning like in their 30s and 40s. We've seen some of that.
Wow.
And that's always that age group that we're worried about. Kids, luckily, that's kind of, I think, all of our silver lining here is like, thank goodness children seem to be okay, especially young kids, because those tend to get, like with flu, influenza in babies is dangerous, RSV. This seems to be not having a big effect on young babies, and that's um, very reassuring to me. But
Excellent. Excellent. And so when you talk about, you said today we saw someone that was very, very sick from it. Um, w- Outside of their findings, outside of their lab work, what's going on? What are they looking like? What what indicators are you looking at that are saying that are telling you outside of their vitals? Are there visual indications that you can perceive in these patients that tell you, man, this person's in bad shape?
often there are. This patient actually looked pretty good, which was sort of surprising to all of us. His numbers looked really terrifying, um, but he looked okay. He was working a little hard to breathe, so that's one we always look for is that just work of breathing. Um, he had been febrile for days and days, so he was dehydrated from losing all that fluid from his fever, and you could tell that. But he actually was. I mean, he was in good spirits. He looked pretty good. He was one of those that I think he's a tough. He's a Navy vet and a tough old guy, and still had a smile on his face. And I think he probably will. And I'm very worried about him that he might not make it. But um, but yeah, I mean, like I said, those vital signs are vital. He had his vital signs were terrible, and that was what was bothering me the most. Um, and he and his labs were really concerning. All those inflammatory markers I mentioned before were very elevated, which is a very bad prognostic sign. And then this virus seems to cause some cardiac abnormalities in about 15 to 20% of patients, and he was showing that, and that's why I was so worried about him.
What kind of abnormalities can it cause?
So I just read this today. Again, this is all we're learning on the fly here, but it can cause like a myocarditis or inflammation of the heart muscle itself, pericarditis or inflammation of that sac around the heart, which can cause fluid buildup around the heart, and it can cause an acute congestive heart failure. And then in this patient, he actually had a new onset of atrial fibrillation, which he had never had before, and his heart rate was in the 160s, which at 83, his heart can't tolerate for very long. So, and I had a
Wow.
really, really, really hard time getting it down. So,
Wow. What a
yeah,
challenge. And,
yeah,
and we've heard so much, and the information's kind of all over the place. And like you
hmm
said, you guys are learning every single day more and more about it. But I've heard so much uh, being the information being repeated of, well, for most people, it's like a mild
hmm
flu-like
hmm
thing, but it seems that as it's arriving on our shores and there's more and more cases, it doesn't necessarily look like that's completely the case. It seems like it's very infective. It propagates very quickly. It creates changes in pathology in the lung even before people have signs and symptoms. And so,
hmm
what's kind of the sense for physicians as they begin to face off with this new virus?
I mean, I think that's still like we suspect it's still about 80% of folks have mild illness. I'm gonna move locations because my battery's low. I'm gonna go plug myself in. Okay,
Okay, yeah,
sorry.
you're fine.
Yeah,
No worries. We can
I
just
have a.
okay, excellent. So, um, there seems to be a profound awareness from many emergency room physicians that they are basically placing themselves in harm's way every day. And I've heard some of my friends say, I've kind of come to grips with the idea that at some point I'm going to get this, or I'm going to do everything that I can to make sure that I don't get it. Where are you standing in your relationship with the idea that you're putting yourself in front of this every single day?
Um, yeah, that's a tough one for me. Because I'm immunosuppressed. I take meds for rheumatoid arthritis, so I'm technically in that high risk group. Um, which I know colleagues who are in that high risk group, they're like, well, I'm not going to see patients. I don't have that option. I work in a small town in a small group, and we don't have enough manpower for me to not work. Um, I also feel very obligated to my community and to my patients to be there and to show up. Um, and I have two little kids, and I'm a single mom, so it's like, what is my obligation to my community, to my hospital, but to myself and my kids? Um, and we had a provider in our community actually die of influenza earlier this year, who was immunosuppressed as well. So it's front and center in all of our minds because it actually happened to our community this winter. Um, so it's been really hard. That's the biggest stress.
Mm,
Um, well, there's two big. That's my biggest stress. Is like, am I being an idiot? Should I just say no? I'm not going to be working. And then the other big stress is just the unknowns. I always want to show up for my patients, know what I'm doing, and be competent and good at my job and take care of them. And I just don't always feel that way with this pandemic. I'm today on this patient today too. I was like, we're trying this new way to give you more oxygen. Are you okay if we try this? He's like, have you done this before? And I said, no, I've never done this before. Um, but it's scary. And I think we're all on edge. Patients are on edge too. I had a not awesome interaction with a family last week. And normally, like, I feel like my communication skills with patients are pretty good. I try to be very empathetic to what they're going through, and I just didn't have my normal empathy and patience because I'm scared. I don't want to be working right now, honestly. Like, I want to be quarantined at home with my kids and playing games and doing fun stuff. And I signed up for this job, and I feel committed to it, and I feel um, yeah, big responsibility. I also live and work in the town I grew up in, and I feel a big responsibility to my community, who has taken care of me since I was an infant. And Um, I want to give back to them, but it's really real for us. It's really real for us on the front lines that we're exposing ourselves to something that could kill us. And it's not like Ebola. Um, still, I feel like our chances of getting something are of getting really really sick are low, but it's higher than my day to day life, and so it's a bit scary. Yeah,
Well, I mean, I know that I'm gonna speak for myself, and I know that for many, many, many of the people that are gonna get to listen to this, as you were speaking, I felt, a heaviness in my heart, especially because, I know you personally. We've been on a medical mission trip together, and I know the type of human
yeah,
being that you are. I know that you have two beautiful kids that mean, the world to you, and I can just feel that pain, that concern, that fear. And at the same time, it's so clear to see your courage and your commitment for the people that you're serving and that you love, even if it's, so against what you might want for yourself. And there's really no words that could ever begin to express uh, what this commitment, at least from what I'm seeing in you and from you. I mean, this is huge, Dr. Greg. This is huge, and thank you so much for what you're doing, for the love that you have for your community, for your patients, for your profession. I know that many times it can be, an uh, a, a challenging privilege, a war in silence, sometimes without getting much recognition or respect, not respect, but not appreciate the appreciation that you should be receiving. And on my end, and I know from all of the people that hopefully will get to listen to you, I want to say thank you so much. We're going to be praying for you super duper hard, and
thank you.
sending all the good energy and all the love and all the strength, and anything that you and your family might need moving forward. Please feel free to reach out. You have a friend in me, and any of the resources or connections that I might be able to gather in your benefit. Always feel free,
Yeah.
to connect. All right,
No,
so
I mean, I appreciate that, and I have seen the positive in a lot of people through this, people, my friends, family, colleague, everyone has been reaching out, checking in on us, seeing how we're doing. Somebody brought us burritos to I mean, people are just doing like, people really, really, really wanna help. Um, we have people sewing us hats to cover our hair and masks, and I mean, just really wanting to pitch in and help with anything they can, and so, I do feel appreciated, and I do feel it from everybody, so I thank you because that helps. Again, like, when we have those interactions where we don't feel appreciated, it feels hard because it doesn't feel worth it. And overall, it feels worth it right now, and I mean, I overall feel like it's a privilege to care for people. It's my life's work. It's what I love doing, and yeah, we signed up for this and we knew it would be hard at times. So
well, Dr. Drake, thank you so much. I have a million other questions, but I'm so mindful of your time. I know it's
no, I
already
appreciate
getting
that.
late, and it's time to go to bed and rest up and enjoy the rest of your evening. So thank you so much
You're
for
welcome.
taking some time out of your private and personal life and dedicating it to us. I pray that this information is going to be very helpful and very valuable for people that are, really looking for actionable, for reality, not for,
Yeah,
the hopeful little rainbow or the
yeah,
doom and gloom. People are really looking
right.
for information that is useful, that is valuable, that is helpful. And I'm so excited about everything that you've given us tonight, because I really think it's going to make a big difference for a lot of people that are out there and beginning to understand, what's going on behind the scenes. So thank you so much. Is there anything else that you would like to add before we wrap up?
No, thank you, Ruben. It's nice to see you, and please stay home, people, when you can.
I am.
Help us
I
out.
am.
Help us out.
Yes, absolutely.
Okay.
Have a great night, Dr. Drake, and thank
You
you.
too. Thank you.
Bye.
Okay. Take care.